Hi, I'm Dr. Rosemary Babo, and I am an operating room nurse as well as medical affairs education specialist. I have come together with my friend and colleague, Marianne Sanford, to help bring to you best evidence practice and hopefully some solutions to what you can implement in your own facility.
Yes, and hi, I'm Marianne Sanford. It's great to have you with us today. We appreciate you. I'm a registered nurse and operating room nurse, also for medical affairs, where we work with all kinds of operating room folks all around the country.
So let's cut to it. Today, we're going to talk about preference cards and why updating them and cutting down on unnecessary running in and out of the room can make a difference to you and your facility. There's plenty of recent studies out there. One of my colleagues actually did a really nice manuscript that has been published through ARN, and it talks about the inventory management system they implemented in their facility, and it ended up saving $500,000 in just 4 months.
You know, that's a significant number. And I found a statistic that talks about the OR supply costs. And what I didn't realize, I mean, you know that they cost a lot of money, but what I didn't realize is they comprise an average of 15 to 40% of hospital costs. So that $1 million savings is actually really significant. And it varies, right? So the upper level of that cost has to do with very complicated and complex surgeries, like maybe an orthopedic surgery or neurosurgery, where the 15% might come in with a general surgery, something more straightforward. So, and the OR also accounts for a lot of the hospital's revenue. So it's really important to get that return on investment and keep the costs low so that you can have your revenue be higher.
Well, you bring up a good point about revenue and the cost, and what comes to mind when you talk about that is if you have somebody that's leaving a room because the preference card isn't updated and they don't have the supply there that's critical to this doctor in this case, that means they're opening and closing the door. They're running out. One, we know that anytime you open the door, that changes the atmosphere that's in the OR. It also subjects the patient to unnecessary bacteria that could come in during that. So preference cards, you think it might be a small thing, but all these things add up, not only for the cost savings, but also the number of times that people are taking their eye off the patient. And patient safety is the number one thing, right? And they having people come in and out because a preference card isn't updated. How does that affect patient safety?
Yeah, the literature also talks about the fact that these publications on preference card management have increased since 2003. So that's when we start to see more of a discussion about preference cards. So it is a big deal. And anything we can do in the operating room, preference cards or other things to increase the safety and decrease the workload for the OR staff, of course, is welcome and really critical.
And how do you think that affects even picking for the cases, the hours that are, we have staff that are pulling things that are unnecessary for the case. So preference card doesn't just mean something isn't on there. It could be pulling supplies, a bunch of supplies that aren't even needed. And, whether they're opened or not, that's another thing. But why don't we just clean up the preference cards, take some time, and have that as a quality improvement project in your facility and publish the same as the others do, what your results were. Let people know, we took this initiative and it helped. And that's what the C-level suite really wants to know is how what you're doing not only affects the operation as a whole, but also what kind of employee you are. Are you taking initiatives? Are you paying attention to things like this? And yeah, we all know it's super busy, but if you can cut down on that busyness and have more time to focus on the patient, that's a win for everybody.
You know, some hospitals have ready pick cases that they have to add to. And those tend to be a little bit more straightforward because then you have most of the bulk of all what you need, and then you could add to it on an emergent basis from a preference card. What's more concerning is when you're pulling emergently a case cart and then having to add those supplies. And that could be more challenging. Sometimes a preference card only gets you 80% in the door, right, with the things that you need. But um, preference cards, to me, preference cards are an art. It's an art form, right? To be able to get it in a way that's meaningful and helpful and not have too many things on there that, as you said, things that are pulled that are unnecessary or add-on items that you need to run for or ask your team leader to run for. So to be able to have that as simplified as possible, that's what we're aiming for today is a discussion about that and how we can make it a meaningful discussion, a meaningful commentary on preference cards and the literature. We'll talk a little bit about the literature as well.
You think it's an art form, huh? I
Ew.
just thought it was. I just thought it was the surgeon who wants what he wants when he wants it, and that's something else I think that facilities have been very successful in, and the literature does support that peer pressure. That here's your preference card, this procedure. Here's this other doctor's preference card, same procedure. Why do you have all these things? And really comparing, is this necessary, or are we just pulling this because this doctor thinks that maybe he might use that or she might use that. So I don't know in art, we'll see.
Well, here's my
There is an attitude.
here's my rationale for saying that. They're not a static document, right? They require a lot of attention, some cases more than others, some people more than others that have changes in their technique. Sometimes it feels weakly, but that's okay. We accommodate that and work with that information. But they really need massaging all the time or just even a gut check to make sure that that information is correct. And that takes a lot of time. So that's something we wanted to talk about is the workload that the nurses or other staff have to manage preference cards. I know some facilities have a dedicated preference card person that may or may not be an OR nurse. That might be materials management or your supply area. But when you're thinking about any size facility and the surgeons that they have, typically the staff is smaller for a smaller hospital. The workload to manage something that's so critical to the operating room can be really extensive depending on how you're approaching it. Are you approaching it weekly? Are you approaching it as ad hoc as you're in a case? So we know based on the literature, the one that you were speaking about before, that it will add to the workload, never mind doing the surgical case or pulling supplies.
And we like it when the surgeons go and learn new techniques and new ways of doing things. So I think that you brought up a very valid point. They're fluid, and we certainly don't want that preference card to be put in stone. Of course, it's in the computer system, easy, I think, to manipulate. Depends on, like you said, the workload, but it definitely should evolve over time, and as new procedures and new techniques are developed, and the training of the surgeons are changing as well, so can the preference card.
Right. Rosemary, why don't you talk a little bit about that study that your colleague had done, that quality improvement project that they had in the operating room related to preference cards?
Okay. I don't know what all you want me to say about it, but I think it was groundbreaking in that, to me, so much was found as not needed, that they were able to save the facility so much money by just doing this simple, and I use that in a loose term. It was a simple concept. It took implementation. It took, really attention to detail and an overhaul. And sometimes that's not so easy. Oh, you know what? We don't have time for this. Well, time is money, and we actually do need to do this. And it was astounding how much they actually did save. And I think let me see what the numbers were that they had on this. It improved the preference card accuracy 7%. The add-on supplies were decreased by 20%. And the cost per procedure, and this I think is unbelievable, went down $86.72, which a total savings was $260,000 with that automation just there. So that's a lot, to any facility. And you mentioned smaller facilities. Even with larger ones, you multiply that out. If somebody has 24 ORs, that's a lot. Or, they're doing 87,000 surgeries a year. So you think, oh, our preference cards are really streamlined. Maybe, maybe not, you
Maybe.
know?
And that in within that study, I read that it isn't just a linear or a simple let's fix the preference cards kind of a task. In this particular case, they had to involve their hospital IT department. And we all know hospital IT departments are probably understaffed. So to involve them in that was very smart, but can take some effort. So that's why I say there's an art to it, and you're using technology to help you, which is great. And you and I know of some third-party systems that will take that information and load it into software that tells individually about clinicians and what their percentage is of using or not using supplies so that you can have some accountability, because a lot of times what happens is the clinician in particular says, no, that's not what happens. I always asked for that suture, or I always asked for that screw or something. And that's actually sometimes not the case. So it allows for individual accountability. That can also happen with homegrown software, but it is a heavy lift. It's a big deal. So if you're thinking about doing something like this study, which, by the way, we'll make sure that we have a link to in the podcast so that you can study it for yourself.
Mhm.
You can read it for yourself.
Among others on the same topic. Yeah.
Yes, on the same topic. So the thought process is you may be able to take this on within your own facility and not necessarily have to have a third party.
Mhm. Always promoting a quality improvement project within the unit. Um, it's good training. It's also another really great way to get to know people as well, because as Marianne mentioned, maybe you go to the IT department because you want the data to support what you're saying. Maybe you've never spoken to anybody down in the materials management. It's a nice way to network as well, and you can also put it on your resume. So never turn down a quality improvement project, and this might be the perfect one to start with.
Yeah, it's something important to consider also when you're thinking about making such a data analysis or a data capture, right? Because the point of capture, of course, is within the operating room, whether it's in our the radio frequency tag or it's scanning, whatever it might be. There's resistance. People don't like change and people don't like additional workload. So something to consider is how are we going to improve it and get the data out, but also how are we going to get the data in? Because of course that's just as critical. And expecting resistance, completely normal. In particular in this study, they did it for 4 months, and what they noticed was there longer than 4 months, but they noticed that the first 4 months there was a lot of resistance to it, and
Mm.
even with training over that 4 months, there was just this element of resistance from some people, whereas other people really felt, yeah, it may increase my workload. I recognize that, but I understand the end result is going to be an improved preference card. And over time, my experience with this and my picking for this particular surgeon and procedure will be better. So, but it's really important to understand it may not be for everybody, and getting 100% buy-in is just not possible.
Right. So that brings me to our next episode. Make sure you join us for speaking up and how we can do that all together in the OR.
Yes. And what we have to say is, okay, it's time for the count. So we have to go. But thank you so much for joining Cut to It. We'll see you next time.